obviously dinner tonight, 6:45 downstairs. I think that's all we have to say, isn't it? My name's Andrew. This is Anthony. Welcome.
Let's just enjoy the session.
Done. All right. So the rules of engagement are we've got 10 minutes for each talk and then 5 minutes for questions. So our first speaker is Dr. Stanley Bart. Stanley. Stanley is a physician trainee currently pursuing training in intensive care at the Royal Adelaide Hospital, and the topic for his talk is pulmonary function testing does not predict post-operative ventilation requirements after elective cardiac surgery accurately to guide individual patient resource allocation. Thank you, Stanley.
Thank you, ladies and gentlemen, for and all the organising committee for giving me this chance to come and talk. I think all of you may have looked after cardiothoracic patients, and during your time, you may have asked the anaesthetist what's the pulmonary function test, or you may be having troubles looking at pulmonary function tests. So I decided to conduct this retrospective study looking at where do pulmonary function tests predict post-operative ventilation requirement after elective cardiac surgery. So as we all know, elective cardiac surgery accounts for significant surgical and ICU workload in Australasia. There's increasing comorbidities, and we see a lot of very complex surgical patients that come through our intensive care units. And I think the paramount importance is to look at the efficiency of how we allocate our resources, and also we should have patient-centered surgical outcomes and surgical planning, hence this study. So the objective of the study was to look at all the pulmonary function tests that were performed on all elective cardiac surgical patients that presented, and to see whether there was some association with any risk and complications. And the objective of my study was to look at whether pulmonary function test parameters requirement were associated with prolonged post-operative mechanical ventilation. So this was a retrospective, single-centered observational study done on all patients admitted to Royal Adelaide ICU during July 2013 to December 2017. We looked at all the elective cardiac surgical patients, and I looked at all the pulmonary function tests that were performed. The data that I used was consists of 3 data that looked at all the NZEX data, all the cardiothoracic, Australian, New Zealand cardiothoracic surgical data, and the pulmonary function test that was done in our hospital. And we did have a ethics committee approval prior to studying the study. So the methods, they were quite complex statistical methods used. So we looked at the binary outcome, that's prolonged mechanical ventilation. We looked at the invasive ventilation using the 4th quartile. And the statistics that we used were univariate as well as multivariate variable logistic regression, and then I looked at the receiver operator curve areas. So I'll show you all those when I present my results. So of all the 1,139 patients that presented, 837 of them had pulmonary function tests, which consist of 74 patients of our population. The average age group, the mean age group was 65 years. There were 221, or 26% of them were females that came in. With regard to the procedures, 47% of them had grafts, bypass valves. There were 36% of patients. The combined valve and grafts, there was accounted for about 16%. The mean sort of, this is the intracortal range of invasive mechanical ventilation. We had the average hour was 9.1 hours. So looking at the results, looking at the univariate predictors of my study, the post-operative, post-bronchodilator, forced vital capacity, and the DCO were the two sort of best univariate predictors of my study. We looked at the multivariate logistic modeling, adjusting for age, the BMI, and the left ventricular ejection fraction perioperatively, the forced vital capacity of less than 80% predicted, and a DCO of 15 mils per minute were the best. They have a strong association with that. And then the area under the receiver care was 0.7%. This is the area under the receiver care. Basically, it shows you have the true positive on this axis here, the false positive on this axis, where this intersect is about 0.2. What it shows, we had an odd ratio of 5, almost 5. So the strengths and limitations of my study, it's the largest data set that we have in a tertiary referral intensive care unit. A majority of our patients underwent pulmonary function tests. The limitations of this study is that it is a retrospective analysis, and it depends on the accuracy of the data that's been captured, and the collinearity of all the multiple pulmonary function tests being measured. So in conclusion, there is a pulmonary function test. There's a strong association with a pulmonary function test and prolonged mechanical ventilation. It is inadequate discrimination of this, and routine perioperative pulmonary function test may not be justified. I'd like to acknowledge all the following people who've helped in my project. Thank you very much.
Now, we've obviously got some time for questions. Michael, do you want the microphone?
Thanks very much for that presentation. Pulmonary function testing, I think most people would think it's sort of part of the folklore of working patients up for cardiopulmonary bypass. And you know, so I would ask you the question: why do you think it's not discriminatory? I mean, were you surprised by the finding, and do you have an explanation for why the testing is not adequate to identify the group that would have more prolonged mechanical ventilation?
My study was basically to look at the resource allocation and its utility, and looking at the pulmonary function test. The pulmonary function test, most of our patients that we've looked at were either, so we're all comers, so I think it has a good discrimination there to look at all the patients that came forward. I guess with regard to pulmonary function test and its utility, based on elective surgery, was that it did. There are other confounding variables as well associated with patient-centered outcome and patient, and the morbidity and mortality of other comorbidities that come with patient, and not just the pulmonary function test.
Actually, I have a question for you as well. Did you look at reintubation rates and length of ICU stay? Were there any signals, or did you just look really at length of intubation?
I looked at length of intubation. there was no much reintubation rate for all those patients that we've seen, but I think that we have our questions were basically looking at the length of mechanical ventilation, and I haven't really, part of my data collection will involve ventilator-associated pneumonia and reintubation rate, but I haven't really looked into the data as yet. I don't have that.
And I guess one last quick question from me anyway. Obviously, a lot of our cardiac patients get extubated to high flow, the ones that we're sort of worried about. Was there much use of high flow in these patients, or you just extubate to standard, nasal pro-oxygen therapy, or?
It depends. Most of our patients, we extubate them straight to not high flow, but the CRG, and then transition them to nasal specs. A few, I don't have the data with me, but a few of them who are usually from just anecdotally morbidly obese, who probably have some sleep disordered breathing that are undiagnosed. Those are the ones that we sort of go into a nasal high flow, or some other patients we put them on non-invasive CPAP, and then try and down titrate oxygen when clinically indicated.
Jeff Shaw from Christchurch. Thank you very much. I'm just wondering why, again, it's not discriminatory at an individual patient basis, so the pulmonary function tests. Do you know what the surgeons, the threshold that the surgeons knock the patients back at? I mean, they're not going to operate on some crumbly patient who's got terrible pulmonary function tests on home oxygen walking around in a walking frame, for example. No. I take that one back.
I think that the landscape has really changed much. I work in Launceston, and I used to refer patients down to Hobart. When I came to Royal Adelaide, the types of patients and the cohort of patients that we are tackling at the moment are quite significant, with multiple comorbidities, and they look totally different. So I could not speak for other centres, but for the Royal Adelaide, we tackle quite complex patients. We take patients from all other places, and sometimes I'm really surprised how our patients make it through when they have with those pulmonary function tests. But I think, like everything else in intensive care, things have changed, technology have changed, and so I think a lot of factors involved. But most of these pulmonary function tests, when you have a bad person with a very bad COPD and all that, I think he doesn't take a look in, but other cases have been dealt with. But it just depends on what the clinical indications and what the surgeons tackle.
Okay, I've just got one quick question. So people have prolonged ventilation after cardiac surgery, sometimes because of cardiac or hemorrhage causes, or sometimes it's just because of respiratory failure, pre-existing disease. Did you separate the reason for the prolonged ventilation in your cohort?
I think most of I don't have the data to look at. I didn't really look into. All my primary objective was to look at the length of mechanical ventilation hour. So I wouldn't really differentiate between. But our take-back rates are pretty high as well. But 9.1 hour for mean ventilation is pretty. I would think that is consistent.
Thanks very much. I think in the interest of time, we'll call it there. So thank you very much, Stanley, for a great presentation.